So Justin will be presenting on communication and how it can drive health equity in serious illness. And it's the magic green button.
The green button to go forward?
Yes.
Okay. I'm going to set a timer so I don't take away time from my colleagues. Okay. Good afternoon. Thank you to the National Academies of Medicine and the Roundtable on Quality Care for People with Serious Illness for inviting me here today, and for the vision of its chairs and co-chairs in focusing on this very important topic. I'm really grateful also for the wisdom and experience shared by those who have presented before me and certainly will after me. And I want to say that I come here with a lot of humility. I think as a white male from Utah, it's very exciting for me to be able to be talking with you all about health equity, and I do so with a lot of humility. My goal today is to share with you why I think communication matters for achieving health equity for patients with serious illness and what the role of clinicians might be in delivering communication that addresses disparities in patient experience and outcomes. And I have no conflict of interest to disclose. So in the next 15 minutes, I'm hoping to achieve 3 objectives. First, to highlight communication-related experiences common to patients with serious illness from underserved communities. To consider outcomes which we can focus our sights on to achieve health equity. And finally, to reflect on challenges and opportunities related to improving communication-sensitive outcomes for patients with serious illness. Just to say that I'm deeply struck by the experiences that Jay described in the video we just saw. Near the end of the video, when describing his cancer recurrence, he says, "I think my body is just worn out from fighting all my life. I feel exhausted by the struggle with discrimination and bigotry and poverty." And just to say, we have theory and evidence that suggests the possibility of interpreting Jim's words literally. McEwen and Steller in 1993 described the concept of allostatic load, which is the cost of chronic exposure to fluctuating or heightened neural or neuroendocrine responses resulting from repeated or chronic environmental challenges that an individual reacts to as being particularly stressful. Ample evidence supports a relationship between race and ethnicity, gender, socioeconomic status, and even social relationships on allostatic load. The experiences described by Jay and their perceived or real effects on his health are not unique to Jay, but in fact characterize the experiences of many individuals with serious illness from marginalized communities, those who are the focus of our efforts to achieve equity. Most of my research has been with African Americans, and in my interviews with community members, patients with serious illness, and bereaved caregivers, what sticks out for me are the small traumas and microaggressions to which people in these communities are accustomed, and the well-earned mistrust that many bring to their clinical experiences. A mistrust, I might add, that reflects generations of trauma. Because good communication relates to rapport, and rapport tends to grow with mutual exposure, patients with serious illness often express a high degree of trust in clinicians, fortunately. Cardi Smith presented this image at a recent roundtable on the use of opioids for patients with serious illness in the setting of the opioid epidemic. And as she and as other presenters have noted, health equity is not about ensuring that everybody has access to the same thing, but that the resources are brought to bear in ways that address systematic inequalities in the outcomes of clinical care. And in thinking about health equity in serious illness care, we must think about more than just access to, say, palliative care, specialist, or primary. We must consider the outcomes around which we hope to achieve equity. To use this image, what do we want the small person on the right to see? Care that reflects patients' goals, values, and preferences, or goal-concordant care, has gained increasing attention as an outcome in serious illness care. It's unfortunate that this isn't the sine qua non of all medical care, but our field's focus on this outcome gives us an opportunity for moral and ethical leadership in medicine. Blind luck aside, the only way to allow patients' goals to inform their care is through communication between clinicians and patients and/or their surrogates. Communication enables goal-concordant care. How? So I've been lucky enough to work with Dr. Tulsky to do some thinking and writing about how communication enables goal-concordant care. This theoretical model, adapted from Richard Street's model about how communication heals, identifies the experiences and actions that have the potential to result in goal-concordant care. I'm not going to get deeply into the woods about the complexities of measuring goal-concordant care, although there are many, but I want to highlight the ways in which this outcome, as it's been measured, may actually be problematic. There's a good amount of literature and personal experience, some of which has been described in this room by Dr. Johnson and others, that demonstrates the failures of communication for persons of color and other marginalized communities. We know that there are deficits in every one of the communication quality and process indicators here, the ones on the left. And we have evidence that people from these communities, our communities, experience feeling less informed, less control, less satisfaction, lower quality of life, and less trust in healthcare institutions. So look at the second box. And yet nationally representative studies such as the Health and Retirement Study and the National Health and Aging Trend Study would suggest that there are no differences by race in the receipt of goal-concordant care, end-of-life care, from the perspective of bereaved caregivers. We've been conducting interviews with bereaved caregivers of African American and white patients, and our preliminary analysis of this data has been unsurprising in one way and surprising in another. What's not surprising is the degree to which communication reflects the quality of care. That is, when you ask about the quality of care, you hear about the quality of communication that people receive in healthcare. What has been surprising to me is that no matter how bad communication was or is, no caregivers have said that their loved ones have received care that was inconsistent with their goals. And this suggests to me that we've set a really low bar in healthcare for good communication, in part because my hope would be that people would have a goal or an expectation at least of experiencing communication that feels supportive and improves their illness experience. We know that communication improves care for individuals with serious illness, that evidence links conversations about patients' values and goals to improved quality of life, better patient and family coping, reduced anxiety and depression, enhanced goal-consistent care, more and earlier hospice care, and fewer hospitalizations at the end of life. So if communication is so good, why does it not happen? Well, we know that professional training for clinicians of many stripes does not feature communication skills. I think this is getting better, but we have a lot of catching up to do. Clinicians' implicit biases, some of which are driven by an overinterpretation of what individuals from some communities do or do not want as it relates to decision-making or the elements that support it, such as prognostic communication. And health systems are not designed to ensure that patients have access to good communication. Now, clinicians can be trained to communicate better. We know that that's possible, and there are a variety of programs out there, most of which I would argue are complementary to each other, that support clinician training in high-quality serious illness communication. We need to incentivize clinicians to take advantage of these programs and to ensure that the innovations developed by these programs work their way into undergraduate and graduate health professional training. To touch on bias, we know that clinician implicit bias contributes to health disparities, and I think this is sort of a helpful diagram to think about how that is. So if you look at the top, you see that in the category of discrimination, that persistent discrimination, I don't know if I have a laser pointer, but you can see that persistent discrimination results in physiological and psychological stress. That's the allostatic load to which I was referring, and that leads to racial disparities in health. That physician decision-making based on implicit biases inform disparities in physician decision-making and racial healthcare disparities. And then in the bottom, physician implicit bias shapes disparities in clinical communication, which is what I'm talking about, which leads to negative patient reactions, and which reinforces all the other ways in which we contribute to health disparities. So people have asked, so it goes like this and like that. People have asked if healthcare can be cured of racial bias. I actually think this is the wrong question. Bias is like a chronic illness. It may have a cure in the future, but now it's an incurable disease. However, it can be controlled, and part of controlling it is around educating clinicians about the ways in which bias has the potential to affect their interactions, their communication, and their decision-making in ways that systematically affect one type of patient versus another. And we can work with systems to make sure that bias plays less of a role in making sure that communication happens. So I'll share with you one example of how this can be done. It's one that we've been working on at Ariadne Labs, and we've been advocating an approach that I believe addresses discrimination and bias by attempting to ensure that every patient with serious illness has access to skilled clinician communication. This involves clinical tools, clinicians training and coaching, and systems innovations, all of which are designed to make sure that we elicit and make accessible information about patients' goals, values, and priorities. And so some of those system elements include patient selection of the right patients who are at high risk of dying, preparation of patients to make sure they're prepared for these conversations and expecting them, reminders to clinicians about knowing when to talk, having these conversations, and then documenting them in ways that are accessible at multiple points of care. We've been working with VitalTalk to further strengthen this approach by making sure the highest quality communication skills training is available to health systems and to support them in this work. So to achieve equity, we really must measure communication. Are clinicians trained to initiate conversations about things that matter to patients? Do they feel supported to have these conversations? Are conversations happening? Are they improving patient experiences? And what I'm arguing for is that we may need to spend less time thinking about this really attractive outcome of goal-concordant care, around which there are a lot of measurement complexities, and more time focused on the communication itself and its more proximal outcomes for patients. I was thinking a little bit about trust in the healthcare experience, and if you think about that and its correlates such as satisfaction, I think of what we're trying to do with communication is enhance trust in systems that care for people, in part because that by itself can reduce the health system's contributions to allostatic load, which they certainly do. Patients bring with them to their healthcare encounters the weight of historical injustices and negative personal experiences, which really narrow trust. The effect of this on their experience may be ameliorated over time through the development of rapport with the clinicians that they encounter, but they may experience discrimination or microaggressions driven by implicit biases that, again, constrain their trust in our systems. And I think we can demonstrate respect and caring through communication that, again, enhances trust. And in some ways, the visual, I guess that comes to mind is sort of creating space for people in our health systems where they feel valued and heard. So if health communication has systematically made people feel devalued, then we have an opportunity to utilize communication to repair the relationships that have been undermined over generations. This communication should help people feel seen, heard, and understood. Should focus on goals, values, strengths, and not procedures at the end of life. And it should reflect an intentional focus on achieving health equity. So to revisit this image, I realized that equity in serious illness care is not just about helping one person or another see or achieve some outcome, but it's actually about helping us to see them from the other side of the fence. Dr. Gloria White-Hammond, who's one of Boston's treasures, gave a wonderful talk at the American Academy of Hospice and Palliative Medicine in Orlando last month, and she described a Zulu greeting from South Africa, Sawubona, which means I see you. The response to this is Sikbona, I am here. Communication is the cornerstone of healthcare that can help people feel seen, and they can say to us with confidence, I am here. I leave you with this quote, which has been actually falsely attributed to George Bernard Shaw, it turns out. It's not clear who said it. But anyway, it's still a good one. It's still a good one. We must make clear that communication has been accomplished because it's a key for driving health equity in serious illness care. Thank you.